All right, we are at the top of the hour and it's time to get started. Hello and welcome to today's MIPS Tips session on making the most of your improvement activities. I'm Natalia Wayne, a project manager from Comagine Health, and I want to thank you for spending time with us today. MIPS Tips webinars are a collaborative effort between the three organizations named on this slide, with the goal of providing clinics and clinicians timely information on the quality payment program and to give you a chance to ask your questions related to this program. Between Comagine Health and Mountain Pacific, we support practices in a variety of states. So a few housekeeping items before we get started. Please take a moment to locate the chat feature in this webinar platform. Links to the resources that the presenters share will be posted there throughout the webinar. This webinar is being recorded, and the resource links shared through the chat, a link to the recorded webinar, and a copy of the slides will be shared with attendees and registrants in an email following this webinar. If you would like to download a copy of the slides so you can follow along with today's session and take notes, I will put a link in the chat where that can be located. The slide deck and recording are also available on the Comagine Health and Mountain Pacific websites following this event. You can find slide decks and recordings from our prior webinars along with a lot of valuable QPP resources there as well, so please visit those websites. We have very experienced presenters today that will be going through a lot of information, and we want to make sure to answer your questions. You will remain on mute throughout the webinar, but you can use the chat feature to interact with our team and the presenters. So please feel free to share your thoughts, comments, and questions with the entire audience by choosing the All Panelists and Attendees option in the chat platform. Members of the team will be monitoring the chat and will bring your questions forward to our presenters during the moderated Q&A session at the end of today's webinar. Your feedback is very important to us. So when you leave the webinar today, we ask that you provide your feedback on how we did and on topics of interest for future webinars. Please watch for the evaluation survey link and please take a moment to fill it out. Thank you. So one last thing before we get started, we have a poll question of our audience today. If you are a clinician representing a practice here today, we'd like to know the size of the practice you are with. So I'm going to launch this poll. There we go, and give you just a moment to answer if you wouldn't mind. Seeing those answers come rolling in, thank you so much. I'm going to give it just another second. And we'll stop, thank you so much. All right, I'm going to share those results. It looks like 15 or fewer is the majority of today's audience. So thank you so much for taking time to answer that question. So I'm now going to turn things over to our very first presenter today, London Manor Peterson. London.
Thank you, Natalia. Appreciate that. Hello, everybody. Thank you so much for joining us. So we're going to start today's webinar with the assumption that you already know the basics of the MIPS program. It's divided into 4 categories: quality, promoting interoperability, cost, and the category that we're going to spend today focusing on, which is improvement activities. As a side note, if you do need more help with the basics of MIPS, like Nat mentioned, we've got all kinds of resources, pre-recorded webinars, all of that on our websites. That will be available on a slide at the end for you to look at and visit our websites if you do need those resources. But like I said, today we're focusing on improvement activities, which make up 15% of your MIPS final score for a total of 40 points. So for improvement activities, those are meant to be done in a continuous 90-day reporting period. And you can choose what 90-day reporting period you use within the year. New for 2020, if you're doing group reporting, at least 50% of the clinicians in your group should be performing that improvement activity. However, they can perform the activity during a different 90-day segment during the year. So I wanted to talk a little bit about the points that you get for improvement activities. Typically, a clinician would submit 2 to 4 improvement activities for the year. You can see the weights there at the bottom of the screen. But if you're a small practice, which means that you have 15 or fewer clinicians, or if you're a rural practice, you get double points for your improvement activities. That would mean you only needed to do 1 high-weighted or 2 medium-weighted for the whole year of reporting. Now, if you're in a larger practice, you would double those. Next slide, please, Nat. All right, so I want to make sure that you guys are double checking the CMS inventory of improvement activities. Every year they're making some updates and changes. Sometimes they're combining improvement activities, sometimes they're deleting them, they're getting rid of them altogether, and sometimes they're making changes to the documentation. So if you, next slide please. If you go, we'll start with finding your improvement activities. I think that's a basic place to start. So you go to qpp.cms.gov. And I've got some visuals here on the screen, but if you have a second monitor, you're welcome to follow along. You will go, like I said, to this website, and on that top, you'll see there's a MIPS tab. If you click on that, it's gonna bring you that drop-down box. You can check your participation status there, but what we're gonna focus on today is exploring your measures and activities. So when you click on that Explore Measures and Activities box, next slide, please. We are going to see this. It's a little description of how to use this tool. You're gonna wanna make sure that your performance year is set to 2020. I've noticed sometimes it pulls up 2019. So just make sure that it's set to this year, and you're gonna scroll over to the Improvement Activities tab. Next slide. Now here, this is where you really get into the nitty-gritty, choosing your improvement activities. You know, this is where you can look at your activity weighting. Say you're a small practice and you just want to do 1 high-weighted. You could put it on your high-weighted improvement activity and it'll pull up the list of all the high-weighted ones to choose from. Or you could put in a subcategory name. Say you wanted to work on antibiotic stewardship. You could put that in there and it would pull up the different improvement activities that are related to that. I would suggest that you download and look at all of the documentation requirements for your improvement activities. So next slide. So here you can add to the list and then download just the ones you wanted to look at, or you can download the entire file. It'll come in a zip file. Then you can read the documentation suggestions and the basic outline of what their thought is for an improvement activity. Next slide. I wanted to point out that there is a new improvement activity this year for COVID-19 clinical trials. So if you find yourself a practice that's dealing with COVID-19 patients, there is some registries that you can sign up with to do a clinical trial, and you would get credit for an improvement activity this year. Next slide. So this is kind of flashing forward, right? Because you went through, you selected your improvement activity, you read how to document it, you implemented it in your practice. How do you report it? So at the end of the year, when you go to do your regular QPP reporting, you sign in to the QPP portal, and there's a couple of different ways you can do your improvement activities. You might have submitted through a registry, and they'll turn that in for you. Otherwise, you would sign into this website and you can attest to the improvement activity that you did or upload a document. I wanted to point out that the patient-centered medical homes, they get full points for participating in improvement activities by attesting to being a patient-centered medical home. But for this year, I think it's 50% of the brick and mortar needs to be certified as a patient-centered medical home to get that credit. Next slide, please. This actually, I'm going to hand over to Perrin. Perrin?
All right, very good. Thank you, London. Very good information. So at this point, we're going to talk a little bit about what you want to try to focus on and what you want to try to accomplish with your improvement activities. So the overall goal of this category, and for all categories for that matter, is to improve performance in your practice. to look for opportunities to align with other MIPS categories where possible. So we want to be looking at ways of improving quality of care, reducing cost, improving connectivity with your HIT, and then ultimately help your patients have the best experience possible. Next slide, please. All right, so let's take a look at the process for working with improvement activities. First, you want to identify the areas of your practice needing improvement, looking for meaningful activities or those activities that can align with other MIPS performance measures. Next, we want to identify the validation criteria and suggested documentation for each improvement activity. This will help to ensure that you can satisfy the reporting requirements. Then, look at developing a documentation collection process to cover the selected minimum 90-day time frame that London mentioned. You will also want to identify where your documentation will be retained for audit purposes, and I'll talk a little bit more about that a little bit later. And then make sure to collect the data required for validation of the activities you have chosen. And as Nat mentioned and London mentioned, we have a ton of resources on our website, but I also want to take a moment to let you know and to remind you that we're here to help as consultants. So please reach out to us if you have any questions or need assistance with anything. We're happy to help with that. Next slide. All right. So when you're reviewing your possible improvement activities, you want to ensure you're meeting all the documentation requirements. For example, with this improvement activity, you will see in the suggested documentation section at the end of that first section, there is an "and" circled there. This means that both sections 1 and 2 are needed to meet the documentation requirements. Next slide. Okay, for this improvement activity, we're looking again at the suggested documentation section, but this time you'll notice at the end of that first section, there is an "or" instead of an "and," indicating that you can satisfy either section 1 or section 2, and that would complete that would satisfy your documentation. Now you can do both if you want to, and many practices do, but the examples on this slide and the previous slide are just reminders to make sure you verify that you're able to perform all the documentation requirements as indicated. Next slide. All right, now we want to look at a few examples where improvement activities can help with your promoting interoperability category. Here we see 2 examples. First, practice improvements for bilateral exchange of patient information. And second, implementation of use of specialist reports back to the referring clinician or group to close the referral loop. Working on one or both of these activities would help support your health information exchange objective in the promoting interoperability category. I'll see if I can get that right by the end of my presentation here. All right, great. Next slide, please. Another good improvement activity example in this area is engagement of patients through implementation of improvements in the patient portal. Now, this is a good activity to help support your provider to patient exchange objective, which, as you remember, has no exemption. So that one everyone needs to do or would need to do to get the points possible, but this would help support that. Next slide, please. And one more improvement activity example for this category is the consultation of prescription drug monitoring program, which would be a great improvement activity to choose because of the support it provides for the bonus opportunity under the Query of Prescription Drug Monitoring Program measure. Next slide. Now we'll take a look at a couple of improvement activity examples that could help with your cost measures. First, implementation of analytic capabilities to manage total cost of care for your practice population, and also cost display for laboratory and radiographic orders. Again, tracking this information on one or both of these measures can help you understand more about costs that might be associated with your practice and could be affecting your cost score. Next slide. All right, training and maintenance of certification activities is another area where you can look to align improvement activities with certain certifications that your practice might be interested in obtaining. Now, I won't go through all of these improvement activities, but you can see there are quite a number of opportunities available to satisfy an improvement activity requirement, and at the same time provide certification for you or your staff. Next slide. All right, let's take a look now at improvement activities that correlate with quality measures. Here are a couple examples of measures that align with participating in CAP scores or other questionnaires. So, for example, in quality IA 304, cataracts patient satisfaction survey, that would be a really good one for any ophthalmologic practice, or optometry where there's cataract surgery involved. Next slide. If you're working with diabetics and you're tracking eye exams, A1Cs, medical neuropathy, or other similar diabetic quality measures, then this improvement activity for glycemic management services would be a good fit to support those measures. Next slide. Here we have 3 quality measures: diabetic eye exams, radiation consideration for adult CT, and prevention and screening for flu immunization. Now, these measures would correlate very well with this decision support improvement activity opportunity. Next slide. All right, medication management quality measures are tracked by many practices. So if you're working on any of these or similar quality measures, then medication management practice improvements would go along quite nicely with these quality measures. Next slide. Okay, focusing on care transitions is also performed by a number of practices we work with. This is common in quite a few of them. So as we can see, there are a number of improvement activity possibilities that would work well with these care transition measures. Next slide. Okay, so let's talk a little more about documenting your improvement activities. I first want to emphasize, I'll talk about that first bullet here in just a minute, but I first want to emphasize that your documentation should demonstrate consistent and meaningful engagement during the period for which you are testing. And just as a reminder, this needs to be for a minimum of 90 consecutive days. Also, make sure you document the beginning and ending dates for your improvement activity. So this is very important. The last opportunity to do that this year is October 3rd. It would take in the last 90 days of the year. So whenever you start, or if you started, make sure that those beginning and end dates you've got those recorded. And then you can do the same improvement activity you did last year or in previous years if you would like, as London mentioned, but just make sure the improvement activity is still available for 2020. So check the information there. And then you want to make sure that you're demonstrating that new and continued activity for that improvement activity. So you just make sure that you're tracking those days, making sure that that information is up to date and available. Next slide. All right, and finally, I want to mention a little bit about documentation retention requirements and best practices, retention, access, and storage. So first, you'll need to retain your validation documentation for 6 years from the end of the MIPS reporting period. So for example, you'll need to keep that documentation through 2026 for IAs that are reported for this year, 2020. Next, we recommend that documents should be retained as a hard copy and electronically and in the cloud storage if possible. So the reason being that using several different storage methods ensures that a copy is available in case of disaster in more of one of these areas. So if your offices catches on fire and burns to the ground, or you have a flood and all your documents are lost, you have electronic storage or cloud storage, and consequently, if you lose your computer information, you have paper or cloud storage. So it's just a good way to back up your information that you're keeping. Also, it's recommended that more than one person in practice have access to the documentation. So if there's staff changes or the person responsible is out on leave or something along those lines, there's still someone available who knows where the documentation is stored. And then it's also a best practice that any information about the validation documents be located in the practice's procedure manual, or somewhere where anyone can find that information, or where in the practice it's located in a place where it's easily accessible. All right, now I'm going to hand this over to Seema. Take it away, Seema.
Hello, everyone. Thank you so much, Farrell. That was really good information. He demonstrated how it is, if you can align the various categories, it's going to help you reduce work, but at the same time, the outcome is much more, you'll see the different outcome. So I am here today to talk about telehealth as it relates to improvement activity. Because of COVID, we all are living in a world of telehealth. Some practices may have started telehealth after pandemic. Some may have been doing earlier and now may be trying to get some more extra telehealth visits. I have some examples of improvement activity here as it relates to telehealth. Depending on your practice, some of these activities may not be applicable. There are several ways telehealth can help you with the improvement activities. I'm sharing some ideas and try to be innovative. Improvement activity is all about bringing improvement in your clinic, in patient's outcome. So try to think about innovative ways on how to use the various improvement activities in your practice. So the first one is use of telehealth services that expand practice access. It's basically the telehealth virtual visit, as well as how you are using that visit for improving the workflows in your practice or improving the access to patient. Next slide, please. Use of certified EHR to capture patient-centered report outcome. This is an interesting one. It's about home blood pressure monitoring, blood glucose monitoring, and I have some examples which I will discuss in my later slide. Next slide, please. Anticoagulation management improvement. Clinicians who prescribe anticoagulation medication and manage patients' INR usually have some kind of program in place. Have you thought of managing using remote monitoring or telehealth, especially for your rural population? And there are some codes which I have seen some practices using, which is coming in later slides. Next slide. Engage patients and families to guide improvement in the system of care. As we all know that there is a big push for engaging patients on sharing data, activating patients in their care, and keeping physician and patients in contact through the appropriate sharing of patient-generated health data. Clinicians usually using a patient engagement platform, those efforts may qualify for this kind of improvement activities. Next slide, please. So a very high level about various kind of telehealth services and how it is relevant to MIPS. Telehealth and telemedicine, usually the terms are used interchangeable. Under telehealth, there are various different kind of services. First one is telemedicine. Telemedicine is a live interaction between patient and provider. It includes both audio and video. It is essentially a substitute of office visit and is reimbursed accordingly. During pandemic, CMS has waived some restrictions like allowing patients to connect from home, which has allowed for rapid adaptation. Relaxation with HIPAA compliance platform. But I really think it is very important to use HIPAA compliance platform. Earlier, before pandemic, new patients weren't allowed for telemedicine visit. But with pandemic, new patients can also be seen through telehealth. Some platforms, good platforms, HIPAA compliant platforms, Skype for Business, Zoom, Doximi. Non-HIPAA compliant are regular Skype, Google Hangout, and definitely Facebook Live and Twitch are not allowed. So if you're still struggling with the platform, to try to say, for example, if you're struggling with Zoom because your patients have to create an account and log in, and you're trying to change a platform, for example, Doximi, which does not require an account, is just a small click, and here the whole conversation can happen. That is an improvement, and yes, so you qualify this as an improvement activity. So point being is that you know how you are improving the access of service. So it's one small example there. Now we all know that about 150 codes are allowed for telehealth services. For new patient, the codes are 99201 to 99205, and for established patient, it's 9921 to 99215, with place of service 2. Before Medicare used to use a modifier, but now they change it, place of service 2. So just as a reminder, consent is still required. There may be some copay. The next visit is a virtual visit, which is only a telephone call. In 2019, Medicare began to reimburse for telephone or a virtual check-in in a very specific way. Brief 5 to 10 minute communication with patient using phone. It's essentially for established patient. It has to be initiated by patient, but everyone has a little bit different take on it. Communication is not related to a medical visit within the previous 7 days and does not lead to a medical visit within next 24 hours. For this as well, a verbal consent is required, and there may be a copay. The code for this one is Z2012. The next one is e-visit. This started this year in January 2020. It is essentially a non-face-to-face communication, which is initiated by patient. So the communication, like from portal messages, text messages, emails, we all know that how long some of the portal messages can be from patient, and sometimes it can take good amount of provider time to write those messages. It is for established patient. Again, the consent is required, and there may be some copay. Depending on what kind of coverage. For Medicare Part B, there may be. For dual, they may not be. So it all depends what kind of insurance they have. This is essentially a time-based accumulation of communication that occurs over 7 days. Reimbursement is based on amount of time billed. And I do understand that it is kind of hard to keep track which patient was seen, which wasn't, which qualify, which doesn't qualify. In 1 to 2 doc practice, it works very well, but in a larger practice, it may require some kind of a software update or some kind of software to keep track of it. So, but these are some ideas for you guys to start thinking. And this definitely also helps with the revenue. So something to continue thinking. The next one is care management. Very specific in their care management, like we talk about chronic care management, which is for patients with 2 chronic disease, at least 20 minutes of minimum billing time, non-face-to-face non-face-to-face time with patient or with anyone in the team who is helping with the patient care. Again, for this, it requires a good solid workflow in the clinic to keep track of time for 20 minutes. And if it goes above 20 minutes, you can still bill for it. And this is a really good way to help with the care coordination and as well as generate some revenue. Interprofessional consultation. This is a good one. I really like this. It's like a substitute for curbside consultation for providers. Providers can call another provider on the phone and bill for that time. There are services of providers, organizations which provides online consultation. You work with them. It's a minimum fees per month. And it really works if you just need it, like really, if a provider has some small basic questions, you connect with them through internet, someone gets back to you within 5 minutes. It prevents one extra visit to a specialized doctor, say for example, before going to cardiologist, if cardiologist suggests, hey, get this test done before patient comes and sees me. So it does help with your patient saving one extra visit, which means managing your referrals, which means helping you in your cost category. So think in that way and it will make a sense for you. Remote physiological monitoring. This is a very vendor-driven program. This is basically end-to-end electronically monitoring patient physiological parameters, which includes blood pressure, blood glucose, weight. I have seen these services using in the big hospitals because there are several studies which shows that this does prevent readmission rates, especially if your patients are in the, require some kind of cardiac monitoring. This service really helps. It's some investment. You need vendor or some kind of device where you can do end-to-end electronic monitoring. But if you are performing any of the service, you may qualify for one of the improvement activity we talked earlier. Next slide, please. So some other codes, and try to think this more as how can we use innovatively in our clinic. And if you can show patient outcome, that, if helping with patient to improve, and if it's helping you to prevent ER visit, that is an improvement. So for example, self-monitoring codes for blood pressure, so the 7.3 is to valid device for clinical accuracy, which means patient can bring the device at your clinic and whoever is setting that device, that time is billable. And 7.4 is self-measure collection of data and reported by patient or caregiver. Interpretation and report of rhythm stripe is for 3-lead EKG. Anticoagulation management 93793 is used for non-face-to-face assessment of a new test done at home or in the office or in the lab and providing instruction to the patient. I believe that there is another code which you can bill for if you are helping patient with the home equipment setup and with education. Next slide, please. So because we are talking about telehealth, I thought this is a good, important information for you all to know. So there are some measures which are eligible for telehealth visit, whereas some are not. So for example, hemoglobin A1C poor control. This is eligible for telehealth visit, and we'll talk how it, why it matters in our next slide. Next slide, please. So this slide, I put this here because this is a screenshot of A1C specification from claims measures. So when I want to see more detail on what CPT codes are covered, what are not, to help me understand, I usually go to claims measures. So for example, even if I'm working on ECQM measures, which are EHR reported measures, but this one helps me to understand more detail. So for example, you will see here there are telehealth codes, but if a telehealth visit was not eligible, it would say at the bottom that without GT modifier or POS. So I just put here as an, if you want to know more about what CPT codes, what are eligible, what are not eligible, sometime claims measures helps to understand, because if you look at ECQM measures, EHR measures, they usually talk in terms of value set, and it's hard to understand. So just as an FYI, this. Next slide, please. So here, preventive care and screening body mass index and follow-up plan. So this is a screenshot from ECQM measure, and here you see how it says telehealth eligible, and no, it is not. And why this matters? Please go to next slide. So so this is a workflow. Say for example, a practice has 100 patients and has in-person visit with 50 of them, and the rest were telemedicine or virtual. For BMI measure, note that it says that it's excluded from a telehealth visit. And if you look at the specification, it will say that telehealth modifier, either GQ, GT, 95 or place of service O2 are excluded from the measure. Therefore, the practice would report this measure for 50 patients. If the measure was not met for, if the measure was met for all the patients visits, the practice would have a performance rate of 50 out of 50, which means 100%. Telehealth visits are not counted in this case. Similarly, for A1 measure, since it does not exclude telehealth visit, therefore practice will report the measure for all 100 patients as a denominator, but the numerator will be depend how many you're capturing. If you are capturing all 100, then it will be 100, 100, otherwise it will change. Next slide, please. So on July 2nd, 2020, CMS released a guidance document on allowance of telehealth encounter. There are about 42 eligible quality measures for the 2020 performance period. Interestingly, for 2021, there are 39 only. So, and I would strongly suggest to read those, and that will help you on making sure how to talk to your vendor, and if vendor is capturing the telehealth visits or excluding. So make sure you work with your vendor if you're doing ECQM measures, which is EHR measures. If you're doing registries, make sure you talk to your registry. And if you are doing claims measure, go to claims measure specification and read about it. Another thing is quality payment program hardship exemption application, which recently CMS posted. It's if your practice is affected because of this pandemic, if practice is not able to see a patient, if not able to see patients, or if it's closed, practices can apply for hardship exception. And what that means is they don't have to participate in this program for 2020 without any penalty. It is based on approval from CMS. The reason I put this here is, say for example, if you're really heavily doing telehealth, would it really make sense for you to do hardship exemption? Look at your measures and think in that way, that you know how it matters to you in your practice. You know your practice best. So that's the whole reason. Also, when you're choosing the measure improvement activity, this year may look different because preventive visits might be difficult. We might see more patients in the clinic who are chronically ill. So how are you going to approach? So you might want to revisit your measures, improvement activity, cost, and see that, you know, if it's, do you need to do any strategic planning, change anything, or how do you keep up with those? Next slide, please. So as we spoke, improvement activity is all about bringing improvement in your practice. It's bringing improvement in patient outcome, provider satisfaction, but overall goal for CMS is to reduce the cost, especially that ER visits and hospitalization. So I would say that think MIPS more as MIPS as a whole program. What in improvement activity in telehealth, how is that applicable to your quality measures? How is that applicable to your cost? Say, for example, if telehealth is preventing one ER visit, your cost scores will matter. If you're preventing one extra specialty visit, your cost score may look different. So think in that term and see what kind of alignment you can bring in your clinic with MIPS program on all different categories. So choose the activity that works with you, with your practice, which is meaningful for you, and what provider are interested into. Thank you, Natalia.
All right, thank you so much, Seema. So before we go to the Q&A portion, we'd like to gather some more information from you to help us with future events. We'd like to know how many of you are currently utilizing telehealth. So I'm going to launch another poll. Bear with me one moment. There we go. You should see that pop up. If you would take a moment to go ahead and register your answer. Getting the answers in now. Thank you. I'm going to give it just another moment. All right, stopping polling. It looks like yes, up to 25% of patients is the one that won out. So you should see those results on your screen. All right, thank you so much. I'm going to go ahead and move on to questions. We have time for questions from our attendees. If you have not already done so, please use that chat feature to type in your question. And I have Miranda Brzezinski with me from Mountain Pacific Quality, who's going to help me ask some of the questions to our presenters. Thank you, Miranda.
No problem, Nat. So it looks like one of the questions we got is pertaining to the telehealth improvement activity. And looks like they want to know how involved they have to be for that improvement activity. Is it like a quality measure, or how in-depth do improvement activities have to be done?
Great question. Any of our panelists want to answer that?
Seema, I think you're on mute.
Okay, I can answer that. So again, improvement activity is all about bringing improvement. Look at the documentation, validation document, and look at your practice and see what kind of improvement you can bring. And that is all about improvement activity. Be innovative, try new ideas, and document. That is what I would say.
Okay, it looks like we have another one, and this concerns the 50% of providers having to complete the improvement activity, and this has to do with the telehealth as well. What if there's not 50% of the providers in the clinic conducting telehealth meetings with patients?
Yeah, so that is true. That is one of the biggest concern this year, that how do we get 50% of our providers, especially in rural area, if providers are contracted, they come once in 2 months to see the patients. So again, what we say, so I will give some examples here. Say, for example, if you're doing, if you're participating in patient survey, present those results in your meeting, staff meeting, where you are covering your 50%, at least 50%, more than 50% of providers who are there. Tell them what you're doing with that survey and how are you bringing improvement. So these are like innovative ways of thinking how to cover 50% of your providers. So if you go back to that slide, Natalia, where we start about telehealth, where I just want to show something. Two more, yeah. Okay, yeah. So here, if you see use of telehealth services and analysis of data for quality improvement. So I do understand, given the rush, it's not possible that 50% providers may immediately start on telehealth visit. But if you are doing some kind of improvement, analyzing data, sharing with providers, involving your staff on how you're trying to bring a improvement, I think you can still use this as an activity, and you can say, yes, we are trying to include 50%, at least mobile 50%, 100% of your providers. This makes sense, Miranda?
It does. So just to clarify, just because the providers aren't actually doing telehealth meetings doesn't mean that they don't qualify if the entire practice itself is involved in the improvement activity around telemedicine. Is that correct?
Yes.
Great. Okay. Do we have any more questions in the chat?
It doesn't look like it. I will give another opportunity for anyone who has any follow-up questions to ask them of our knowledgeable presenters. Otherwise, we will end a few minutes early and give you some time back in your day. Last call. All right, wonderful. So I'm going to let us wrap up a little early. Before we go, please make sure that you fill out the evaluation survey on today's webinar. Put the link in the chat right now. We want to make sure that we get your thoughts on today's webinar and that your feedback on topics of interest to you can be used to create future webinar content. So please take a moment and fill that out. If you want or need additional assistance from us on this or any other QPP topic, and you are in one of the Comagine Health or Mountain Pacific Quality Health states, please feel free to fill out our short assessment form, and one of our knowledgeable staff will contact you. Those states again include Alaska, Guam, Hawaii, Idaho, Montana, Nevada, New Mexico, Oregon, Utah, Washington, and Wyoming. Those links are now in chat. If you are interested in learning more, CMS also has created several learning modules to help understand and succeed in the quality payment program. So you can access those modules by creating an account at this website. That is about all for today. I want to thank everyone for participating in the MIPS Tips webinar. If you have any questions, please feel free to reach out to the staff in your state. These are the contacts for the Mountain Pacific states. I'm going to pause one moment so you can copy that information, but please remember that this is in the PDF of the slides, which will be made available right afterwards as well. And these are the contact information, contacts for Comagine Health states. All right. Thank you all again so much and enjoy the rest of your Thursday.
Thank you.
Thank you.